Welcome back. Let's dive right in. Question 1. A 72-year-old with heart failure presents with increasing shortness of breath and a 4 kg weight gain over 3 days. Labs, Na 134 milliequivalent/L, K 3.9 milliequivalent/L, BNP elevated. Which action should the nurse take first? A. Restrict oral fluids to 1 L/day. B. Administer prescribed 4-furosemide now. C. Offer salt-free crackers and water. D. Obtain a 12-lead ECG. Correct, B. Rationale/strategy, signs of fluid volume overload with dyspnea and weight gain, loop diuretic, 4-furosemide, relieves pulmonary congestion quickly. Restricting fluids alone is slower. ECG not first unless arrhythmia suspected. Question 2. A post-op patient has urine output 20 milliliters per hour for 3 hours, dry mucous membranes, HR 120, BP 86 50 seconds. Which 4 fluid is most appropriate initially? A. 0.9% normal saline bolus. B. D5W infusion at 75 milliliters per hour. C. 0.45% NaCl bolus. D. Lactated ringers at maintenance rate. Correct, A. Rationale/strategy, hypovolemia with hemodynamic instability requires isotonic crystalloid bolus, NS, to expand intravascular volume. Hypotonic fluids could worsen hypotension. Question 3. A patient with SIAD has serum Na 122 milliequivalent/L and confusion. Which intervention is highest priority? A. Oral salt tablets. B. 3% hypertonic saline infusion with careful monitoring. C. Fluid restriction to 800 milliliters per day. D. Administration of dimeclocycline PO. Correct, B. Rationale/strategy, severe hyponatremia with neurologic symptoms requires controlled hypertonic saline to raise sodium safely while monitoring for osmotic demyelination. Fluid restriction and meds are next-line/stable options. Question 4. A diabetic in DKA has K 5.6 milliequivalent/L but is about to receive 4 insulin. What should nurse plan? A. Give sodium polystyrene sulfonate, Kxalate, immediately. B. Start insulin and monitor potassium closely, prepare to give potassium when it falls. C. Delay insulin until K is lowered. D. Start loop diuretic to lower K. Correct, B. Rationale/strategy, insulin shifts K into cells and can cause hypokalemia, give insulin but prepare to replace K as needed. Delaying insulin risks hyperglycemia/acidosis complications. Question 5. A patient on long-term loop diuretics has muscle cramps and paresthesias. Labs, K 2.9 milliequivalent/L, Mg superscript 2 1.2 mg per deciliter. Which is best next action? A. Give oral potassium chloride and schedule magnesium repletion. B. Give 4 calcium gluconate now. C. Start 4 potassium and magnesium replacement promptly. D. Increase loop diuretic dose to correct edema then recheck. Correct, C. Rationale/strategy, severe hypokalemia with low magnesium, both should be corrected, for if symptomatic/severe, because low Mg prevents K repletion. Calcium not indicated. Question 6. A patient with chronic alcoholism has tremors, tetany, and an ECG showing prolonged QT labs, Ca superscript 2 6.5 mg per deciliter, ionized low, Mg superscript 2 low. Best immediate treatment. A. For calcium gluconate and 4 magnesium sulfate. B. Oral calcium carbonate and outpatient follow-up. C. For sodium bicarbonate. D. For potassium chloride. Correct, A. Rationale/strategy, symptomatic hypocalcemia with cardiac/neuromuscular signs needs 4 calcium. Alcoholics commonly have low Mg which must be corrected concurrently. Question 7. A burn patient, 40% TBSA, is 6 hours post-injury. What fluid plan is best in first 24 hours? A. Crystalloid according to Parkland formula, RL. B. 0.9% NS boluses to keep urine greater than 0.5 milliliters per kilogram per hour, no formula. C. D5W to replace insensible losses. D. Colloid, albumin, only for resuscitation. Correct, A. Rationale/strategy, Parkland, RL, guides initial resuscitation for major burns to prevent under/over resuscitation. Colloid used later if needed. Question 8. A patient receiving TPN develops decreased respirations and confusion. ABG, pH 7.50, HCO3 elevated, PaCO2 53 mm of mercury. Which electrolyte disturbance could explain metabolic alkalosis? A. Hypokalemia from TPN formulation. B. Hypercalcemia. C. Hypermagnesemia. D. Hyponatremia. Correct, A. Rationale/strategy, hypokalemia causes shift of H into cells and bicarbonate retention metabolic alkalosis. TPN can cause electrolyte imbalances. Question 9. A patient with acute pancreatitis has Ca superscript 2 6.8 mg per deciliter and Schwastek sign positive. What mechanism explains hypocalcemia? A. Fat necrosis binds calcium, saponification. B. Renal excretion from loop diuretics. C. Excess vitamin D intake. D. Hyperparathyroidism. Correct, A. Rationale/strategy, pancreatic fat saponification binds Ca superscript 2 causing low serum calcium. Treat underlying disease and give calcium if symptomatic. Question 10. A post-op patient on metolazone, thiazide-like, develops confusion and seizures. Labs, Na1 18 milliequivalent/L, osmolality low. Which is the safest correction approach? A. Rapid infusion of 3% hypertonic saline to correct to 135 immediately. B. Slow correction with hypertonic saline to raise Na by less than or equal to 8-10 milliequivalent/L in 24 hours. C. Give hypotonic saline to dilute serum. D. Give 4-calcium gluconate. Correct, B. Rationale/strategy, severe hyponatremia with neurologic symptoms needs hypertonic saline but corrected slowly, less than or equal to 8-10 milliequivalent/L/24H, to avoid central pontine myelinolysis. Question 11. A 55-year-old with chronic kidney disease, GFR low, has hyperphosphatemia and low calcium. What med helps lower phosphate? A. Oral calcium carbonate with meals, phosphate binder. B. Furosemide. C. Oral potassium supplement. D. For magnesium sulfate. Correct, A. Rationale/strategy, calcium-based phosphate binders reduce GI phosphate absorption. CKD patients often need binders to manage hyperphosphatemia. Question 12. A patient with hypermagnesemia, Mg superscript 2 6.0 mg per deciliter, is hypotensive and has diminished deep tendon reflexes. Which is priority? A. For calcium gluconate to antagonize Mg effects. B. For magnesium sulfate bolus. C. Start oral magnesium oxide. D. Fluid restriction. Correct, A. Rationale/strategy, for calcium antagonizes cardiac/neuromuscular effects of Mg while other measures, fluids, loop diuretics, dialysis, address removal. Question 13. A burn patient shows rising hematocrit and tachycardia in first 24 hours. This indicates A. Intravascular dehydration, third spacing, continue aggressive fluids. B. Fluid overload, stop fluids. C. Hemodilution from overresuscitation. D. Improved fluid balance, taper fluids. Correct, A. Rationale/strategy, rising HCT plus tachycardia post-burn suggests plasma loss into interstitium, continue appropriate fluid resuscitation. Question 14. A patient with hypernatremia, Na1 57 milliequivalent/L, and decreased skin turgor arrived from a nursing home. Best initial nursing action. A. Replace free water slowly, oral or D5W, aiming to decrease Na less than or equal to 10-12 milliequivalent/L/day. B. Rapidly lower Na with 0.9% NS bolus. C. Start hypertonic saline. D. Give oral salt tablets. Correct. A. Rationale/strategy. Chronic hypernatremia requires slow correction to avoid cerebral edema. Assess volume status and correct free water deficit carefully. Question 15. A patient in renal failure on hemodialysis has K 7.2 milliequivalent/L with tall peaked T waves. You're waiting for dialysis. Which is immediate action? A. For calcium gluconate to stabilize membranes, plus insulin/glucose to shift K. B. K-exolate only. C. Give 4-potassium chloride bolus. D. Encourage high-potassium foods to stimulate excretion. Correct. A. Rationale/strategy. Cardiac stabilization with Ca superscript 2 then shift K intracellularly, insulin plus glucose, are immediate, dialysis is definitive. Question 16. A patient on chronic PPI therapy has hypomagnesemia and refractory hypokalemia. Why does low magnesium cause persistent hypokalemia? A. Low Mg increases renal K wasting by impairing Na/Kat posse repletion and increasing ROMK activity. B. Mg and K exchange in the gut only. C. Hypomagnesemia causes insulin release that lowers K. D. Mg deficiency causes acidosis which raises K. Correct. A. Rationale/strategy. Mg is needed for cellular K uptake and to reduce renal K wasting. Replace Mg to correct refractory hypokalemia. Question 17. A marathon runner collapses after race, HR 48, BP 92/60, muscle cramping. Labs, NAL 118, K 3.8. Which is likely cause? A. Exercise-associated hyponatremia from excessive hypotonic fluid intake. B. Hypernatremia from sweating. C. Hyperkalemia from muscle breakdown. D. SIAD from sweating. Correct. A. Rationale/strategy. Overconsumption of plain water plus continued sodium loss in sweat causes dilutional hyponatremia. Treat carefully, hypertonic saline if severe neurosigns. Question 18. A patient receiving high-dose 4-vitamin C has a sudden rise in serum creatinine and oxalate crystals in urine. Which electrolyte abnormality might follow? A. Hypocalcemia due to calcium oxalate precipitation. B. Hyperkalemia due to renal failure only. C. Hypernatremia from fluid shifts. D. Hypermagnesemia from vitamin C. Correct. A. Rationale/strategy. Oxalate binds calcium causing hypocalcemia and renal failure. Monitor Ca and renal function. Question 19. An elderly patient on ACE inhibitor and spironolactone presents with muscle weakness and ECG changes. K is 6.3 milliequivalent/L. Which factor likely contributed? A. Combination of ACE inhibitor and potassium-sparing diuretic causing hyperkalemia. B. Excessive loop diuretics. C. High sodium diet. D. Low creatinine. Correct. A. Rationale/strategy. ACE inhibitors reduce aldosterone retention of K. Spironolactone is K-sparing. Together risk severe hyperkalemia. Question 20. A child with cystic fibrosis has hyponatremia and dehydration after heavy sweating. Best parent teaching? A. Replace sweat losses with oral rehydration solution containing salt, not plain water. B. Give only water to prevent hypernatremia. C. Avoid salty foods permanently. D. Give diuretics to prevent swelling. Correct. A. Rationale/strategy. CF patients lose high amounts of NaCl in sweat, need salt-containing rehydration to prevent hyponatremic dehydration. Question 21. A patient with COPD is receiving long-term loop diuretics, now has metabolic alkalosis with low Cl. Which fluid would help correct metabolic alkalosis? A. 0.9% NaCl, isotonic saline, to restore volume and chloride. B. D5W to provide free water. C. Lactated ringers without potassium. D. Hypertonic saline. Correct. A. Rationale/strategy, volume depletion plus chloride loss maintains metabolic alkalosis. Isotonic saline restores volume and Cl to help kidneys excrete bicarb. Question 22. A post-thyroidectomy patient has perioral tingling and tetany. Calcium 7.0 mg per deciliter and albumin normal. What acute treatment is appropriate? A. For calcium gluconate slowly and monitor ECG. B. Oral calcium carbonate only. C. For potassium chloride. D. For magnesium sulfate only. Correct, A. Rationale/strategy, symptomatic hypocalcemia post-thyroidectomy, possible hypoparathyroidism, requires 4 calcium with ECG monitoring. Question 23. A patient with SIAD is asymptomatic with Na 128 milliequivalent/L. Which therapy is most appropriate initially? A. Fluid restriction and monitor. B. Rapid hypertonic saline infusion. C. For loop diuretics immediately. D. Start hemodialysis. Correct, A. Rationale/strategy, asymptomatic mild-moderate hyponatremia from SIADH, conservative management, fluid restriction, first, meds if chronic/resistant. To stay updated with future videos like this, don't forget to like this video and subscribe to the channel. Question 24. A patient on total parenteral nutrition, TPN, for weeks has edema, weight gain, and decreased sodium. Which is risk of refeeding syndrome when starting full dextrose? A. Hypophosphatemia due to insulin-driven cellular uptake of phosphate. B. Hyperkalemia due to increased intake only. C. Hypernatremia due to TPN tonicity. D. Hypermagnesemia due to protein intake. Correct, A. Rationale/strategy, refeeding causes insulin release shifts phosphate, K, Mg into cells hypophosphatemia with risk for respiratory/cardiac issues. Replace electrolytes and start slowly. Question 25. A patient with acute adrenal insufficiency, Addisonian crisis, presents with hypotension and hyponatremia. Which electrolyte abnormality is expected? A. Hyponatremia and hyperkalemia due to aldosterone deficiency. B. Hypernatremia and hypokalemia. C. Hypercalcemia only. D. Hypomagnesemia only. Correct, A. Rationale/strategy, low aldosterone Na loss and K retention. Treat with glucocorticoids/fluids and correct electrolytes. Question 26. A client receiving amphotericin B for systemic fungal infection begins to have muscle weakness and arrhythmia. Labs show K 2.8 milliequivalent/L and Mg low. Nurse should A. Hold amphotericin and notify provider, replace K and Mg. B. Give oral potassium supplements only. C. Continue amphotericin and observe. D. Start high-dose calcium infusion. Correct, A. Rationale/strategy, amphotericin causes renal K and Mg wasting, medication may need adjustment and electrolyte replacement urgently. Question 27. A patient with severe metabolic acidosis, pH 7.10, has hyperkalemia 5.8 milliequivalent/L. What explains hyperkalemia? A. H moves into cells in exchange for K moving out, extracellular K rises. B. Increased renal excretion of K due to acidosis. C. Acidosis increases aldosterone release causing K retention. D. Acidosis has no effect on K distribution. Correct, A. Rationale/strategy, acidosis causes H to enter cells and K to leave, hyperkalemia. Correct acid base and monitor K. Question 28. A woman develops SIAD from small cell lung cancer. Which lab pattern is expected? A. Low serum osmolality, low Na, concentrated urine, high urine osmolality. B. High serum osmolality and high urine output. C. Low urine osmolality and high sodium excretion. D. Hypernatremia with dilute urine. Correct, A. Rationale/strategy, SIAD retained water, low serum Na and osmolality while urine remains concentrated due to ADH. Question 29. A patient with severe vomiting for several days develops metabolic alkalosis. Which electrolyte abnormality perpetuates alkalosis? A. Hypochloremia and hypokalemia, renal bicarbonate retention. B. Hypernatremia and hyperkalemia. C. Hypomagnesemia only. D. Hyperphosphatemia only. Correct, A. Rationale/strategy, loss of gastric HCl, low Cl and volume depletion, kidneys conserve bicarbonate, hypokalemia worsens alkalosis. Question 30. A patient with severe sepsis requires aggressive fluids. Which statement about crystalloids versus colloids is true? A. Crystalloids, NS/LR, are first line, colloids may expand plasma longer but lack mortality benefit. B. Colloids should always be used first for sepsis. C. D5W is ideal for intravascular volume resuscitation in sepsis. D. Colloids do not affect oncotic pressure. Correct, A. Rationale/strategy, evidence favors initial crystalloids, colloids like albumin used selectively. D5W distributes to intracellular space, not ideal for resuscitation. Question 31. An ICU patient on continuous diuretics has Na 128, K 2.6, Cl low, and weakness. ECG shows U waves. Which medication will help retain potassium? A. Spironolactone, potassium-sparing diuretic, but use cautiously. B. Furosemide. C. Hydrochlorothiazide. D. Mannitol. Correct, A. Rationale/strategy, potassium-sparing diuretics reduce renal K loss. In acute severe hypokalemia, K replacement is primary, spironolactone is adjunct and must be used cautiously with renal function. Question 32. A trauma patient receives 5 units PRBCs rapidly and develops hyperkalemia. Why? A. Stored blood releases K over time, rapid transfusion can raise serum K. B. PRBCs lower serum potassium. C. PRBCs contain no potassium. D. Hyperkalemia is unrelated to transfusion. Correct, A. Rationale/strategy, stored RBCs leak K, monitor K during massive/rapid transfusion and consider washed cells or slower rates if risk. Question 33. A patient is being treated for hyponatremia with 3% saline. Which monitoring is essential? A. Serial serum sodium every 2 to 4 hours and frequent neuro checks to avoid overcorrection. B. Only daily weights are adequate. C. Check sodium once after 48 hours. D. No monitoring required if infusion rate is low. Correct, A. Rationale/strategy, hypertonic saline can rapidly change Na, frequent labs and neuro assessment are vital to prevent osmotic demyelination. Question 34. A patient with chronic alcoholism is started on 4-thiamine and glucose and then develops respiratory failure. Which electrolyte deficiency might have been unmasked causing weakness? A. Severe hypophosphatemia, respiratory muscle weakness. B. Hyperkalemia, muscle weakness. C. Hypernatremia only. D. Hypercalcemia only. Correct, A. Rationale/strategy, refeeding, glucose plus insulin, shifts phosphate intracellularly. Hypophosphatemia can cause respiratory muscle weakness and failure. Monitor phosphate. Question 35. A neonate with pyloric stenosis shows hypochloremic metabolic alkalosis. Best initial fluid to correct? A. 0.9% NaCl with KCl replacement as needed. B. D5W only. C. 3% saline. D. Lactated ringers without K. Correct, A. Rationale/strategy, replace chloride and volume with isotonic saline, correct K after volume and acid base begin to normalize. Question 36. A patient on lithium for bipolar disorder develops polyuria and hypernatremia. What is mechanism? A. Nephrogenic diabetes insipidus, lithium impairs renal response to ADH, water loss and hypernatremia. B. Lithium causes SIAD. C. Lithium increases ADH secretion. D. Lithium causes hyponatremia by salt retention. Correct, A. Rationale/strategy, lithium can cause nephrogenic DI dilute urine, free water loss, hypernatremia. Manage by stopping lithium if possible, give amiloride. Question 37. A patient with cholera is severely diarrhea dehydrated. Which fluid replacement is preferred initially? A. Rapid isotonic crystalloid, NS or RL, to restore intravascular volume. B. Oral hypotonic solutions only. C. D5W alone. D. Hypertonic saline. Correct, A. Rationale/strategy, severe volume depletion needs rapid isotonic fluid resuscitation, oral rehydration can be used when stable. Question 38. A patient with acute liver failure shows hyponatremia. Why is hyponatremia dangerous in hepatic encephalopathy? A rapid correction can precipitate central pontine myelinolysis and worsen cerebral edema, careful correction is needed. B. Hyponatremia has no effect on encephalopathy. C. Hyponatremia helps reduce intracranial pressure always. D. Hyponatremia lowers ammonia levels. Correct, A. Rationale/strategy, brain adapts to chronic hyponatremia, rapid correction risks demyelination. Manage carefully, prioritize neurostatus. Question 39. A woman in labor receives an epidural with high-dose local anesthetic and then becomes hypotensive. You anticipate which electrolyte/volume issue to correct? A. Hypotension due to sympathetic block, treat with 4 fluids, crystalloid, and vasopressors as needed, electrolyte correction not primary. B. Give 4 calcium to reverse epidural. C. Give hypertonic saline. D. Give 4 potassium. Correct, A. Rationale/strategy, epidural-induced sympathetic block causes vasodilation and hypotension, bolus crystalloids and vasopressor support are appropriate. Question 40. An alcoholic patient has low phosphate and hemolytic anemia after parenteral glucose. What is underlying link? A. Hypophosphatemia impairs 2,3-BPG and ADP production hemolysis and decreased oxygen delivery. B. High phosphate causes hemolysis. C. Glucose directly lyses RBCs. D. Hypokalemia causes hemolysis. Correct, A. Rationale/strategy, phosphate is needed for ADP and RBC integrity, refeeding can precipitate hypophosphatemia hemolysis. Question 41. A patient with severe hypernatremia is neurologically intact and hypovolemic. The plan is to replace free water deficit. Which is an appropriate target correction rate? A. Lower sodium by no more than 10 to 12 milliequivalent/L per 24 hours. B. Rapidly normalize sodium within 2 to 4 hours. C. Increase Na to 180 then lower slowly. D. No need to calculate, replace freely. Correct, A. Rationale/strategy, slow correction minimizes cerebral edema. Choose route, oral or 4D5W, based on ability to tolerate oral fluids. Question 42. A patient with hypocalcemia secondary to massive transfusion should receive which treatment? A. For calcium gluconate while monitoring ECG. B. Give oral calcium carbonate only. C. Start phosphate binders. D. Defer calcium until after transfusion complete. Correct, A. Rationale/strategy, citrate in transfused blood chelates Ca superscript 2 causing hypocalcemia, symptomatic or ECG changes require 4 calcium. Question 43. A patient with hyperkalemia 6.1 milliequivalent/L, no ECG changes, is on chronic spironolactone. Next best step? A. Hold spironolactone and recheck potassium within hours. Consider insulin/glucose if levels rise or ECG changes develop. B. Start potassium supplements. C. Ignore because no ECG changes. D. Immediately start dialysis. Correct, A. Rationale/strategy, for moderate hyperkalemia without ECG changes, stop offending agents and reassess, escalate if K rises or ECG abnormalities occur. Question 44. A patient with acute tubular necrosis, ATN, is oliguric and hyperkalemic. Which diuretic strategy helps manage potassium? A. Loop diuretics, e.g., furosemide, may increase urinary K excretion if kidneys responsive. B. Thiazides are preferred in oliguric ADN. C. Potassium-sparing diuretics reduce K excretion. D. No diuretics affect potassium handling. Correct. A. Rationale/strategy. Loop diuretics can increase urinary K excretion if some urine output exists. In oliguric renal failure, dialysis may be necessary. Question 45. A patient with pneumonia on high-dose beta-agonist nebulizers has hypokalemia. Mechanism? A. Beta-2 agonists drive potassium into cells via insulin-mediated and direct increases in Na/K ADPase activity. B. Beta-agonists increase renal K excretion only. C. Beta-agonists increase dietary K absorption. D. Beta-agonists cause K release from cells. Correct. A. Rationale/strategy. Beta-2 stimulation shifts K intracellularly causing hypokalemia. Monitor K during frequent nebulized therapy. Question 46. A postoperative patient receiving hypotonic fluids develops focal neurodeficits and Na falls from 140 to 122 over 24 hours. What complication is most concerning now? A. Cerebral edema due to rapid fall in serum sodium, acute hyponatremia. B. Central pontine myelinolysis from rapid correction, not applicable here. C. Hypernatremia. D. Volume overload only. Correct. A. Rationale/strategy. Rapid sodium drop causes water influx, cerebral edema and focal neurosigns. Treat urgently, consider hypertonic saline. Question 47. A patient with chronic kidney disease and metabolic acidosis, HCO3 15 milliequivalent/L, is started on oral sodium bicarbonate. Nursing teaching should include a. Monitor BP and volume status because sodium load may worsen hypertension/edema. B. Na HCO3 will remove potassium permanently. C. No monitoring necessary once started. D. Stop all other meds immediately. Correct. A. Rationale/strategy. Alkali therapy provides sodium load, monitor for volume expansion and BP changes. Question 48. A child with pyloric stenosis has paradoxical metabolic alkalosis and low CL. The potassium is low. Why is potassium low despite alkalosis? A. Intracellular shift of H out and K into cells to maintain electroneutrality is reversed in volume depletion. Renal K wasting from aldosterone release causes hypokalemia. B. Alkalosis always causes hyperkalemia. C. Vomiting increases dietary potassium. D. Pyloric stenosis causes excess K intake. Correct. A. Rationale/strategy. Volume depletion and secondary hyperaldosteronism cause renal K loss despite alkalosis. Treat with fluids and K replacement. Question 49. A patient with severe hypovolemia is given 5% albumin infusion. What immediate effect is expected? A. Increased intravascular oncotic pressure and plasma volume expansion. B. Rapid intracellular dehydration only. C. No change in plasma volume. D. Causes hyperkalemia. Correct. A. Rationale/strategy. Colloid, albumin, increases oncotic pressure drawing fluid into vasculature, used when indicated, e.g., low albumin, edema with intravascular depletion. Question 50. A patient with acute liver failure has low sodium, 128, and is being evaluated for transplant. Which serum sodium management principle is important pre-transplant? A. Avoid rapid correction of hyponatremia pre-transplant because it increases risk for neurologic complications post-op. B. Rapidly correct sodium to normal before transplant regardless of neurostatus. C. Sodium not relevant to transplant outcomes. D. Induce hypernatremia to decrease cerebral edema. Correct. A. Rationale/strategy. In liver failure/encephalopathy, careful sodium management is crucial. Rapid changes can worsen cerebral edema or cause osmotic demyelination. Coordinate with transplant team.